Right, let me know if you can hear me. And welcome, good afternoon. Good afternoon. Right, let me know if you can hear me. If you join, let me know if you can hear me, okay? Right, so I have 2 hours. Now let's kill it fast. Let me go, okay? Right, okay. Right, can we start? Okay, so, okay, yes, I can hear you. Okay, right, so let me share the screen quick. Let me start, okay? It's going to be this is a crash course thingy, okay? So it's going to be a quick thing. It should be done. Okay. So psychosocial integrity. Okay. Psychosocial integrity. This is one of the areas that you'll be tested at at the NCLEX. Okay, so we're gonna hit on it. In layman, we say psychiatry and mental health, but the area is called psychosocial integrity. Okay, so we are looking at the framework. Anytime you are approaching, I'm showing you this because you are writing your NCLEX soon. Okay, so anytime you are approaching a psychiatric question, okay, ask yourself. Number one, is anyone in immediate danger? Okay. Any question they give you, is anybody in immediate danger? Is there suicide, homicide, violence, severe withdrawal, or severe medication toxicity? Okay. Yeah. What are the cues I'm seeing? And what psychiatry or psychosocial problem best explains them? Okay. And what communication technique is therapeutic? Then what intervention is least restrictive and safest? Okay. Then how will I know the client is improving? Okay. So in short, we have this chain, the safety stabilization, therapeutic relationship, coping, education, and long-term recovery. Okay. So let's start with the therapeutic communication. I said I'm going to run, so be open your eyes. If you don't understand anything, send me the chat box. Okay. Send me message in the chat box. So therapeutic communication is one of the most important psychosocial and class concepts. Okay. In therapeutic communication, client-centeredness and purposeful communication is the key. Okay. Yes. Why do we make the client a center? Okay, or the reason why we are talking, a purposeful communication. Like you and I, we are here for we are here for ATT class. We can't talk about soccer. Okay, if you talk about soccer, it is not a purposeful communication. We have chipped in another area. Yes, so this one is designed to encourage the patient to talk more. Let the client know that yes, make the conversation, tune the environment to make that yes, this is all the communication we are doing favors is about you, okay, and purposeful, okay. Then you assess. It helps you us to assess and problem solving and coping skills, okay. So what are the techniques we are going to look at here? We are looking at the open-ended questions. Okay, the open-ended questions. We did it some months ago, and So anytime you want to ensure that you and a patient had a good therapeutic communication, your question should be open-ended. Okay. So instead of saying, "Are you feeling depressed?" rather say, "Tell me how you've been feeling." Okay, don't let it be like yes or no questions. Okay, right. Then you should, in the communication, in the therapeutic communication, another aspect you are going to look at, apart from the open ended question, is what of offering self. So let the patient know that, okay, I will stay with you. Are you anxious? I will stay with you. Okay, particularly used when this type of technique is used when client is anxious. Okay, so anxiety question, therapeutic communication. How are you going to answer it? Anxiety situations, offering self technique is the most important. Then open ended. Okay, patient is grieving, family member dead, patient is frightened, those phobias and panic issues, panic disorders, or patient is experiencing crisis, offering self technique. Okay, then reflection. So reflection is also another technique under our therapeutic communication. So the client says that nobody cares about me. Okay. Then the nurse will say, you feel that you are alone. So the nurse is trying to reflect the underlying feeling. Okay. All these things help the patient to talk more, to express themselves more, to know that yes, we are doing, or we are doing a purposeful communication. Everything we are talking is about me. So I need somebody to hear me. Okay, right. Then clarification. When clarification is another topic under therapeutic communication. So when you say everything is falling apart, what does that mean? Okay, so you and I know that this question will bring out more answers from the patient. Then another technique you can also use, number 5, is what exploring. You need to explore. You need to explore. Okay, tell me more. So the next to ask, tell me more about what happened. Okay, you're collecting data. Then the next technique is what? Focusing. You mentioned that anxiety became worse yesterday. Okay, let's talk about that. So we are focusing on the statement you made yesterday. Can we focus? Can we talk more about that? That's the focus communication. Okay. Then there's the seventh is what? Presenting reality. If I'm moving so fast, let me know. Okay. If you're not getting anything to let me know. Okay. So it's useful presenting the reality to the patient. It's a technique. So it's useful for hallucinations and delusion. Those people who are having what issues with what contact, touch, and all those stuffs. Yes. So somebody will say that I don't hear the voices. They are hallucination or they are delusional, but I understand that you hear them. Do not validate do not validate hallucination that, oh, you said you cannot hear voices. Yes, it's true. Me too, I cannot hear. Okay, no, we don't do that. Okay, never validate hallucinations. Now let's look at what silence. Silence. Okay, so silence is another technique that you should use. So in therapeutic communication, silence gives the client the time to think, process emotions, organize their thoughts, and continue speaking. Okay, so this is all out. These are the about 8 or 9 techniques you're going to use about therapeutic communication. And remember, therapeutic communication is client-centered and purposeful communication. Okay, let's look at some of the non-therapeutic, which NCLEX does not like. Okay, so don't if you see any answer that falls under non-therapeutic, don't choose it. Okay, like you ask the patient why, avoid. Why did you do that? You are being judgmental. You sound judgmental. Then you telling the patient better. Tell me what happened. What was happening when you made that decision? Okay. Then false reassurances, they are all what? Non-therapeutic communication. Yes, you've communicated, but is it therapeutic or non-therapeutic? We can even use this in our normal day-to-day activity. You've spoken, but is it therapeutic? Will it bring you more information? Can the patient know that something is going like this conversation? I mean, it's about me that I need to give more information. Okay, changing the subject. So this one, if you change the subject, change subjects, you are not making a purposeful communication. Okay, then minimizing feelings. Okay, minimizing feelings. So at least you are still alive. If you make this statement, we always do it. Oh, at least you are still alive. At least, okay, you are still here. At least things did not go well. They are what? Non-therapeutic communication. You are minimizing the feeling. Let the person bring out the feelings more. Talk about it. Then approval and disapproval. You did the right thing. It's non-therapeutic. Then arguing with delusions. That's ridiculous. Nobody is following you. So the key rule is that when two responses appear reasonable, when you are stuck, you don't know which answer to choose. Select the response that goes with acknowledging feelings. You acknowledge, you didn't validate two different words, okay, and meanings. Okay. Acknowledge feelings. Also, the answer that encourages further communication. And lastly, the answer that avoids judgment. Okay, that is it about therapeutic communication. Now let's go. So we are done with therapeutic communication. Let's go to anxiety. Anxiety as a topic under psychiatry. Okay, anxiety as a topic under psychiatry. Okay, so anxiety is a spectrum. It exists on a spectrum. So we have different types of anxiety. Okay, we have mild, moderate, severe anxiety. We have panic. Okay, then we have the higher aspect of it. So we have the generalized anxiety disorder. Then we have the panic disorders. Okay, then we have the OCDs, obsessive compulsive disorder. So let's take them one by one. I'll go. If I'm rushing, let me know. Okay, so we are on the topic anxiety. Anxiety. Okay, so when they say somebody has a mild anxiety, the client may have increased alertness. Yes, the patient is anxious. Sometimes they can be alert or increased alertness, their increased awareness or improved problem solving ability. Okay, so in this case, learning is generally possible. Okay, they are able to listen to you. If you educate them, they are able to hear. Okay, yes, they will give you that kind of attention because anxiety is there, but it's normal. It's like an adult who fears injection comes to your hospital. Okay, yes. So sometimes they understand. You can see that, yeah, they're anxious about the needle prick, but needle stick. Okay, but they have anxiety, but it's mild. Let's go to the little bit, top it up a little, moderate anxiety. So their perceptual field narrows. Okay, so how will you know that this guy is having anxiety? Over here, the vital signs will start changing. The heart rate is increasing, the respiration rate is increasing, the muscle tension, the goosebumps, everything are there. Difficulty concentrating. This one, if you are teaching them, is very difficult for them to pay attention. So when you get a question that tells you that patient is having what difficulty concentrating, you should know that this is not a mild anxiety question. This is a moderate anxiety or higher forms of anxiety. Okay. And even if they want to pay attention, they select. I want this. Okay. They select where to pay attention and where not to pay attention. So in this case, when you are dealing with this patient, you use a short explanation, calm communication, and simple directions in order to engage these guys. Okay, let's go to severe anxiety. So clients have what markedly or significant reduced perceptual field. So difficult thinking, they are trembling. You can see that your body is shaking. They are hyperventilating. It is not only increased respiratory rate, they are very severely hyperventilating. They are tachycardic. Then sense of what they feel that there is a sense of what an impending doom. The way they behave as if the world is coming to an end. Okay. Learning ability. Learning ability. This ability is significantly impaired over here. Okay, is significantly impaired, severe anxiety. So sometimes you need to give them anxiety medications to calm them down, or you de-escalate. Okay, right? Panic. Panic is another form, is a higher form. So over here, client is unable, look at the verb, unable to process complex information. They are unable to solve problems. They are unable to follow lengthy instructions. Okay, so how will they manifest? There is terror, chest discomfort. Some of them will even be having what chest pain, chest discomfort, dyspnea, palpitations, feeling of impending death, and loss of control. So your nursing priority is to stay with this client because safety is a concern. Vital signs are jammed up. Their breathing is, they are having shortness of breath, okay, dyspnea, palpitation, goosebumps, sweating, agitated, breaking things, okay. Yes, so that is a panic disorder. It's like you are sitting in an aeroplane and it's going to crash. This is the state you're going to be. Okay. Reduced stimulation. So your priority is to stay with the client. You reduce his stimulation. If you want to talk to this patient, use short, simple, calm statements. Do not begin detailing teaching during what acute stage of panic. We have higher forms of panic. Okay, this is just panicking. You are panicking. Everybody can panic. We have when the disorder even adds to it. That is crazy. Okay, so we'll get to that. Good. Now let's go to generalized anxiety disorder. Generalized anxiety. So GAD involves excessive anxiety and worrying occurring more days. Okay, this patient, you become generalized anxiety disorder. Okay, when you have excessive anxiety, it occurred today, but tomorrow, next 1 week, 1 month, you are still anxious. Okay, something has happened to you that it is occurring more days than not over an extended period and affecting multiple aspects of life. Okay, we call it generalized anxiety disorder. So, example, patient will be restless. Something they went to town, they came back home. She came restless throughout the whole week. Muscle tension. If they see anybody, then they have the startle. Okay, irritability, fatigue, sleep disturbance. They are not sleeping. Some of them will be walking and talking and all these things. Difficulty concentrating. So what do? At this stage, you need to give them more psychotherapy. Psychotherapy. You should do the cognitive behavioral therapy or the CBTs. Okay. You can give them medication. Not even can, you have to give them medication, SSRIs and SNRIs, which we know, serotonin and norepinephrine. But okay, all those ones. Okay. Then other medications depending on their circumstances. So if vital signs are over the moon, blood pressure over the moon, like antihypertensives and all those ones, yes. So you go higher levels of care. Okay. Let's look at panic disorder. Panic disorder is also another is a higher forms of panic as a word. Okay. And it's also a higher form of GAD, generalized anxiety disorder. So if you look at this guy, panic. They are what? Characterized by recurrent, unexpected panic attacks and concern or behavior changes related to future attacks. So, during the attack, you should always look out the safety first of this patient. So the question can come, the eye engines, it is still ongoing. Patient, okay, during the attack phase, you should always look at what? Their safety. Safety is the priority, safety is the denominator. So what are you going to do? Are you going to leave this patient? No. So you remain with the client, keep encouraging them, make sure that the stimuli, whatever is in the environment, that is a patient is watching television and they are showing a program that is making the patient get panic attacks. Okay, you definitely remove this. Take off. You can off the television or change the program. Stay with the client. Make sure they stabilize before you leave them. You don't have to shout on them. Speak to them calmly. Then you use simple instructions because when they hit panic attack, their thought process, even processing complex instructions is difficult. So what? You speak to them calmly. Then you use simple instructions. Okay. Then you help regulate breathing, the vital signs, deep breathing exercises. Okay. Then assess for physical conditions when clinically indicated. Okay. Now let's look at OCD. So OCD is about obsession and compulsion. It's a compounding. Obsession, they are the thoughts that keeps hitting your mind. The thought hitting your mind. So, example, you have the thought of what? I want to eat, I want to eat, I want to eat, eat. That is the thought. You are sitting down as you are watching me, something is running through your mind, it's hitting your mind. Do this, do this, do this, do this, do this. That is the obsession. The compulsion is the behavior, the act, the repetitive behavior. You got up and you went to eat and you came back. That is not compulsion. But you ate. Even if you are hungry, even if you are satisfied, you are still eating. Eating every day, every minute, that is a compulsion, okay, aspect of it. So this is a repetitive behavior and a repetitive thought. So obsession is repetitive thought, and compulsion is what? Repetitive behavior. So if you have the mindset, if something has told you that, oh, clean the house, the house is dirty, the house is dirty, the house is dirty, the house is dirty, the house is dirty. Okay. And now that is the thought of repeat. You are hearing those voices. And now your compulsion is you get up, you are cleaning. Even if the house is not dirty, you still want to clean. Okay. So we have seen that you have energy for compulsion. So can we give you an activity? Can we give you a catalyst to go and read for us? Because here is bushy. Okay. Yes, we take advantage of your compulsion and use it to help us positively. Okay, that is the compulsion. That is what health workers must do. Okay, so example, somebody has an obsession that he is hearing persistent voice, contamination. Okay, this place is this water is contaminated, or this place is contaminated, this environment is contaminated. He's having that fear, that anxiety. Okay, so anxiety will keep increasing, heightening. Then the compulsion will set in. This guy will be washing the hands, repetitive hand washing. You finish the water and increase the water bill in the house. Okay, so what do? We have to get this guy, instead of wasting the water, why don't we give him the cooking utensils to be washing for us in the house? Okay, yeah. So do not abruptly prevent established rituals. Okay, when doing so would produce overwhelming anxiety unless safety requires immediate intervention. Yes, so this is a clause that you should know. Okay, you don't have to stop them when stopping them will even produce more anxiety to bring agitations and for them to destroy things in the house. Okay. But when safety, when stopping them is necessary, because if you don't stop them, you are going to, and you allow them, there are going to be safety concerns. They can hit somebody, they can harm someone, or can, okay, then you have to stop them. Somebody is having the compulsion that the car that you have parked outside there, he has to move it because he has gone to the gym, so he wants to move it. So he will go and get a rope and come and tie it to the car that he's pulling. Okay. Yes, he will pull, stop. If you don't stop this guy and he moves the car, he's not sitting in the car, he doesn't know how to drive. Okay, it's going to cause accident. It can even, the car can knock him down, or the car can go and destroy properties. That is what this statement means. Okay, so what do we do about this guy? Cognitive behavioral therapy is very important. Exposure and response prevention. Then some medications, okay, can also help. Fine. We are done with anxiety. Let's move to another topic. This is a crash course, so you should understand. You can use one day to finish everything about psychiatry. Okay. Part 8. Okay. Let's go to post-traumatic stress disorder. Post-traumatic stress disorder. So this stress disorder, it follows exposure to trauma. Okay, exposure to trauma. So it will come with a cluster of signs and symptoms that the patient, it will overwhelm the patient, and the patient doesn't have any control over them. That kind of emotional presentations, that patient will have no problem, will have no strength to overcome it. Okay, and remember this, we know that PTSD follows an exposure to trauma, a traumatic event. Okay, yes, everybody and how they explain trauma. So know that when you're dealing with human beings, everybody and how they explain things. So your trauma is not my trauma is not your trauma. There are some people, when their relatives die, oh, they see death as what? Okay, like health workers. When somebody is dying in our hands, okay, yes, the way the family members are traumatized, the way they will be having emotional disturbances and emotional dysregulations, we are not going through that same situation. Okay, so your trauma is not my trauma. I can, or we health workers can go home after the patient has died, go and eat, drink, bath, sleep, go to party, and come back home. But the person whose husband or whose wife or whose child has died, for days, for months, for weeks, they have to even force him or her to eat. So your trauma is not my trauma. Okay. But when your trauma comes, the one that you consider your trauma, when it comes, the afterlife becomes the post-traumatic. And some of the symptoms that you can experience or you can manifest is that you will be having that nightmares, intrusive, persistent, intrusive thoughts and memories. Okay, yes. Sometimes it scares us that we even avoid. We avoid everything about that. We avoid food, we avoid bathing, we avoid going out. We want to stay in bed. We don't want to talk to anyone. We avoid friends and families. We avoid everybody around you. Okay, yes. Then we get these negative changes in mood and cognition. Okay, then sometimes to reactivity or hyper arousability also comes in. Yes. So there are flashbacks, hypervigilance, sleep disturbance, irritability, exaggerated startle reflexes or responses, then what? Emotional detachment from the society and from the whatever. Okay. So how, as nurses in NCLES, how are we going to help this situation? We are going to help with what? Providing safety. Don't encourage them to be avoid. Okay, boys, we can come and take Ayariga to the sports. Okay, we are going to watch soccer. Ayariga, he's sitting at the stadium, his mind is not on us. but we are providing safety. Okay, so come, let's go. Okay, we will not allow you to stay home. Everywhere we are going, we want to make sure that we are with you. Okay, yes, predictability. You should be able to predict the next move by the patient. Otherwise, they will go and kill themselves. Or some of them, some mothers even throw their babies away, through dump them, some one baller and rubbish area. Okay, yes. Then you should provide what choices where possible. Okay, don't give them choices, 100% choices that every decision we want to make, it is your choice we are going to take. No, give them choices. Hmm? We want to make this. Okay, what do you think? Okay, me, I think this way. Oh, this way you think? No, 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 we will not allow you. See, let's go here. Okay, sometimes you are firm on them, sometimes too you allow them their decisions to what to 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 take mastery. Then provide informed communication and respect for boundaries. Okay, avoid forcing detailed trauma disclosure. Yes. Oh, what happened to you? Can you tell me? In that trauma situation, you are not going to ask them, what happened? You want to do this? My husband used to drink alcohol. I have told him, stop alcohol, stop alcohol, stop alcohol. He didn't listen. Today he has got liver failure and died. And you see, some friends will come, oh, what happened? What happened? Can you tell us what happened? You are forcing what? Detailed trauma. Once patient is in a traumatic state, okay, yes, whether you know the story or you don't know, yours is to provide solution. Be with the patient, ensure safety, guide them, protect them, predict their next move. Okay, yes. So that is PTSD. PTSD. Okay, now let's go to what depression. Depression. So we do depression, we do mania, then we do what bipolar. Sure. So depression, just like the way the trauma started, okay, definitely something would depress you in life. That the triggers that would depress you in life, they are not the same as what the triggers that depress me. Okay, there are some people even when their soccer team, their football team loses match, they don't eat, they are depressed. Okay, by me, that is not my depression. Okay. There is somebody when the boyfriend leaves or the girlfriend leaves him or her, okay, they will be depressed. But there are some people too, they are not be depressed. So it is what subjective. This is a subjective situation we are looking at. Okay. Your trigger is not my trigger. But once the problem comes, once your turn comes, we have to help you. How are you going to know that this person is in depression? Okay. Persistent depressed mood, sometimes over days, over hours, over weeks, okay, over months, they will be depressed. It's going to be a persistent. Everybody can be depressed. Okay. Sometimes you wake up, you sleep and you wake up in the morning, you are not in good mood. You are depressed at that moment. But oh, get up, brush your teeth, bath, go out. Depression away. Okay, yes. That one is a transient one. But for you to be persistent, days, months, okay, you need what? Okay, you need somebody to be close to you, to guide you, to help you. Okay, but don't take somebody who will come and take advantage of you. There are some people, what they are waiting for is this person is vulnerable now, so let me go and take advantage. They will come in the name of coming to help you. By the time you realize they've done something with you, they've stolen something from you, yes, those people are hot. They are just tricksters in this life. Okay, this person will be having what? Sleep changes. This is not how you sleep. Okay, they'll be having appetite changes going down. Okay, fatigue, most poor concentration, feeling of worthlessness and guilt, psychomotor changes, and thought of death or suicide. So Enkel's priority will say that what the most dangerous complication is what? Suicide with depression. So never assume that assumption. That's where health workers miss. Never assume improvement in their energy means suicide risk has what disappeared. They will start gifting their properties. Oh, Antenna, today I feel like you have never even given you a gift before. Okay. I saw this nice cloth, this kente cloth. Can I give it to you? You have energy now. All of a sudden, you have energy. Okay. Boys, oh, you there for days. We have been calling you. Let's go and eat. You say you won't eat. All of a sudden, you are rather calling us that we should go and eat. Or you want to come and do bye-bye with us. Okay. Okay. So they will come and eat with you nicely, play with you. The next moment, seaside. Okay. So you should watch for those sudden energy these depressed people get, because it's a plan, it's a trick. Okay. So a severely depressed client who suddenly becomes more energetic may now have enough energy to act. And let me tell you, this all these things are hormonal. You can't lie. Eh? You can't lie. You can't hide it. Okay. You can't hide it. You definitely manifest it in this way. Okay, so on that note, let's enter into suicide. The major warning signs of suicide is what you should watch for: suicidal statements. They are making some funny statement. The other time I was just saying it on this page that in this US, if you go and make any suicidal statement, they will call police for you, and you are not going home that day. You are going straight to psychiatric units. They will take your phone, take everything from you. Okay. Yes. So they will make a statement. They will definitely tell somebody that please, so, blah blah blah. Life is not worth again. This one is not this again. Okay. They will definitely, some of them do write notes down, statements. They are planned. They will plan. Nobody in this world has killed him or herself without planning. They will plan how they are going to execute it. Some will plan that I want to hang myself. Some will plan that I want to overdose myself. Some will plan that I want to go and crash a car and die. Some will plan that I want a train to run over me. That is the plan. So when you get any suicide patient, the idea and the plan, these are the two major questions you should ask them. Do you have any idea? And I mean, this one, no proverbial. Okay. Then you assess for lethal means. You also assess for what? Previous attempts. Okay. Assess for previous attempts. Has this happened to you before? Do you feel like, yeah, the white people, they are honest. They will say it. Okay. They are very honest. Somebody, if they will say it, yes. That, oh, sometimes I feel like killing myself. Okay, how many times now? Last month, last 6 months, last year. Okay, that time, did you have any plan? Did you attempt anything? Oh yeah, I took some Benadryl. I took cough syrup plenty so that I would sleep and never wake up again. Okay, okay, so previous attempts are there. Feeling of hopelessness. You should also watch out for or assess for. Then giving away possessions, saying goodbyes, sudden behavioral changes, substance and intoxication, severe agitation, and recent what, major losses. Okay, right. So the next, you should be direct with your questions. Are you thinking about killing yourself? Even if you are my friend, are you thinking about killing yourself? Do you plan to kill yourself? If yes, do you have a plan? These are the major two questions. Yes. So they are method. If they have a plan, which method? Which means? What time? What is the intention? Is there any previous attempt? So what are the things, protective factors? Okay, right. So even if you go and drink with boys, then you are tipsy. You go and make any suicidal statement, they will call police for you. Simple. So that is it. So the formula is ideation plan. Intent means you put the patient on what suicidal risk. Mm. The risks for the patient you suicidal. So safety is the highest intervention we can give to what suicidal patients. Okay, ensure safety. So one to one, please, suicidal patients, those with plan, those without plan, once you fall, we do assessment, you fall under the suicide. We lock you, we hold you. Sometimes police will hold you, or the medical doctor will hold you. Okay, we hold means we have placed. They will write a note that you are not supposed to leave the hospital under no circumstance unless the doctor discharges you, okay, or the police discharges you. So at that moment, if they hold you, you don't have any right over your life again. The hospital will decide for you. The hospital, they are not taking your right 100% from you. Okay, but for sake of safety, we place a hold on you. Okay, so on that note, we do one-to-one care. One to one, oh, the nurse, you are in charge, you are in the psychiatric arena at the ER. Okay, you are in the psychiatric bay. They've brought a suicide patient, one to one. That healthcare assistant or whoever, the sitter who is doing one to one, he or she is not supposed to get up and leave the patient that I want to go and use the bathroom and come back. I want to go and pee pee and come back. No. The least chance suicide patient gets, they will kill themselves. Okay, if anybody is passing and they see that the patient is alone, nobody is with them, trouble come. If the person wants to go on break, they should tell you. You come and sit there, or you find somebody to come and sit there. They will go. When they come back, then the person goes. Then you do a 15 minutes clicking. Every 15 minutes, what is the patient doing? So we have some chat. Since I chat, you do 15 minutes. What is the patient was doing? Oh, patient was asleep. 15 minutes. What is this? So that is it. You in the room they are. You remove all dangerous objects. You remove. We don't have patient monitor. We don't have any wires. We don't have any drip stand. Okay, with all dangerous things from the room, take it. Make sure the environment is safe. Good lighting, appropriate escalation, and frequent reassessment should also be done. Okay, so that is what suicide. Okay, let's go back to bipolar. So bipolar is what? Two poles. Let me explain so that quick we go. You are here. Every human being is here. Okay. And this is what? Mania. And this is depression. Okay. Every human being, you and I, we don't have issues with bipolar. We are here. But once a while, we get depressed. So we go here, but we don't get stuck here. Then we come back. We readjust. We come back here. Normal life. Life goes on. Sometimes you are depressed. You don't even want to talk to anyone. It's normal. The hormonal mix-ups. Yes. Sometimes you are overly excited. You are manic. You don't have attention. I mean, yes. And people will even be surprised. Why is that today? This guy is so happy like that. So yes, so aggressive and so yes. So sometimes you become a little bit mania, then you come back to normal. Okay, yes. But people with bipolar disorder, they if they are having issue with coming to the center again, to normalcy. This is a normal area. They are having issue. So if bipolar one, if this guy is here in the depressive environment, he will be showing what? Major signs, the signs and symptoms, the behavior. He will be showing what? Signs and symptoms of what? Major depression. Okay? Major depression. But like the magnet, that has what? A north pole and a south pole. How does the magnet conduct? The magnet will conduct electromagnetic waves from the north to the south. from the north to the south, from the north to the south, from the north to the south. Then it goes like that, from the north to the south, from the north to the south. Then the south too will be doing the same thing. The south will be doing the same thing. The south will be doing the same thing. And the south will be doing the same thing. Okay, so cross. So if you are standing here, if you are standing at the North Pole, eh, and the north radiations are spitting out, is moving out, you get higher effect of north radiations than what the south. Yes, the south too is shooting radiations, but the south radiations have to travel a long distance before they get to you. But the north radiations will not travel a long time to get to you. That is it, and vice versa. So that guy with what? Bipolar disorder, depression state, he is getting what? Because he is closer to the depression pole, he will exhibit higher signs and symptoms of major depression. Then once a while, that is why we call it a bipolar. So you are not only exhibiting one-sided signs and symptoms. No, you exhibit all the signs and symptoms, both depression and mania. Just that you'll be having higher, or majority of the signs and symptoms will be coming from the pole you are closer to. Then once a while, they are happy, they will come and play with us, but they don't keep long. Okay, why? Because one radiation from the mania side has traveled to come and hit this guy. So today he's happy with us. Yes, there are some people, they don't know how to become friends. When you are living with them in the house, every day they are moody. Every day, when they wake up, they won't call you. When you are in the house, you are, yes, they won't talk to you. They won't do anything to you. I mean, but one day you'll be there, they will come and knock your door. Okay. Or they will come back from work. You are sitting in front of your door. They will come and stand with you, play with you, smile and chat. Then you'll be wondering, oh, this guy is friendly. So why is it that he's not? Yes, it means that one mania pole has traveled to hit him, so he is happy today. The next moment he will switch. He will switch again. Okay, so they don't keep long when they are happy or they are sad, and vice versa. Okay, so possible when the person is exhibiting manic side, they are always elevated in mood. There is what decreased need for sleep. They are always walking. Mania is the uppers. Okay, they are always excited. They don't sleep. Okay, precious speech. Every aspect of their life is running. It's running. The speech, pressure, grandiosity. Their thoughts is running. They think big. Racing thoughts, distractibility, increased activity, and impulsive or risky behavior. Yes. So if you don't take care, this is a major concern about them. It's a major concern. If you don't take care, they will injure themselves. So you have to always watch them. Okay, keep eyes, especially a child, those who will be doing child support and all these things. The mother has brought the child to you. The child is running, jumping, climbing stairs, they go and break their hand, and you'll be in trouble. Police will come and arrest you. Okay, so safety and nutrition is their major concern, because these guys, they don't have time for anything in life. So for them to even sit down 5 minutes to eat is a problem. You have a husband, that husband does not sit down 5 minutes to eat. You have fufu, but fufu is going to take 10 minutes for us to sit. It's a long time for many patients. So this patient, what do they do? Finger food. Can we put fufu in a bowl so that they will be eating around? No. So what do? You get food that they can hold in their hands. Even when they are walking, they are eating. Okay. Then hydration, they don't get time to drink. They don't get time to sleep. Okay, all these ones are there. Mhm. And low stimulations. So client experience severe mania, may not sit along enough long to eat. So you should provide, if they get the time to eat, make sure they eat and get high calories, high protein, so that their muscles don't waste. Okay. Then portable fluids, structured environment, clear limits. Okay. Then what? Reduce stimulations. Yes. So avoid lengthy debate. They don't have time for you. They'll rubbish you and go. Okay. They don't have time for you. Okay. Now, mania. You are doing bipolar. We've done mania. Okay. The mania or the bipolar. Okay. We need a medication to what? To stabilize. To stabilize. We've already done the depression. So you know the depression. We've done the mania. Okay. Lithium. You can't do bipolar without this medication called lithium. Lithium has a very narrow therapeutic index. Okay. Therapeutic. Any medication you take, the medication has a narrow therapeutic index, or the medication has a long therapeutic index. Okay. So if I give you paracetamol, I've given you 500 milligrams, 200 milligrams, 1,000 milligrams. Okay. Maybe paracetamol's index, therapeutic index is what? Let's say from 2,000 to 4,000. 2,000 to 4,000 milligrams. Then you are taking, taking. You've now you have entered into this zone. Okay. When you cross the 4,000 and you keep taking paracetamol, it means that what? You are going to build up toxins. You are going to build up what? Excess amount of this medication in your bloodstream, in the serum. Okay. And your body will start exhibiting signs and symptoms of the side effect of that medication. That is it. Okay. So lithium has a very narrow therapeutic index. So you don't have to take lithium plenty before it hits here. And those medications with narrow therapeutic index, when you take it, you have to wait. The first one you took, make sure that what? There is none or just a few amount in the blood before you take another dose. Because when you pile the dose, let's say you've taken lithium 8 a.m. and the next dose you are supposed to take is what? Tomorrow 8 a.m. Then you say, "Oh, I'm feeling this day," so you went to take. I'm having mania and bipolar symptoms. So I want to take 10 p.m. You went to take again. If you take the 8 a.m. one, you cause what? Overdose. You get toxicity. Then you begin to get the side effect of what? The lithium, the higher levels of what? The side effect. That is all about lithium. So we use lithium to stabilize these guys. I told you that bipolar, they have a problem with what? So this is the depression and this is the mania. We normal human beings, or we those people who don't have problems with this medication, they are always in the middle. So lithium will also bring these guys to the middle, yeah, to stabilize their mood. It's a mood stabilizer. Okay. Some of the side effects, common ones, somebody who is taking will be having what? Tremors, GI, increased thirst. Okay. It dries you. See, is a runner. It's a runner. So it will calm your mood, but muscle activity, nervous activity, fine ones. Okay. Test, it will dry you quick. Okay, why is it drying you? You sometimes you have what? Vomiting, diarrhea, So you quickly lose fluid. Okay. Yes, increase urination and all those are minor ones. Okay. But when you take higher doses and you cross to the toxic zone, you begin to see the worst of worst. So the fine tremor you are getting here, over here, you are getting cause trauma, confusion. Your brain is overly processing information. Okay, unsteady gait or ataxia, slurred speech or pressure speech, significant neuromuscular changes. There can be seizures in severe toxicity and vomiting and diarrhea like a pregnant woman in first trimester. They are vomiting crazily. Okay, yes. So if you get any question with cause trauma, vomiting, confusion, ataxia, suspect or toxicity, cool. Okay, that is about seizures. Yes. Let's go to schizo. Schizo. Any question? Schizo. Okay. So schizophrenia. These guys have what? Disturbances in their thought processing, cognition, perception, how they perceive, how they see things, how they see life. Not with eyes or not vision, perceive. Okay, their behavior, we are calm, they will not be calm. Okay, if everybody is supposed to be calm at that moment, they will not be calm. Okay. When the whole masses are going here, they are having issue, right? Behavior, okay, all those ones, emotional disturbances and functionally. Can you tell the schizophrenic patient to go and sit in a mathematics class and be solving calculus or algebra? Okay, they don't function in those aspects. Higher level functions, cognitive functions, they have issues there. So in schizo, we say what in schizo we have the positive and the negative symptoms. So the positive are what? Your normal body functionings or your normal lifestyle, but you have added a new lifestyle, a new behavior to the norm, your baseline. That wasn't part of you. So we have what? Hallucinations, delusions, disorganized thoughts, behavior, whatever. Okay. Yes. The negatives. It has been taken, all these behaviors have been taken from years. You are living, you are somebody who is always happy. All of a sudden, you are not happy again. You are flat affect, blunt, mood, sad, evolution, you don't talk. Okay, allogia, anhedonia, you have no interest, social withdrawal, and all those stuffs. So you are withdrawing like somebody who has what? Depression behaviors. Yes, so these are the positive and the negative. So if you want to know the memories, I've added them here. You should get the slide. This is a crash course. So let's take them one, the positive. Let's take them one by one. Hallucinations. We are not going to do these ones. We are not going to do all these ones. But we will do what? The positives. The hallucination and deletion. Then we move. Okay. So a human being like you and I, we've never hallucinated before. We went to sleep and woke up. We are having issues with our perception. What everybody is seeing as black, only you are seeing it as white. Okay. What everybody is seeing as food, only you are seeing it as a stone. No matter what we say, you said it's a stone. Are you joking with us? Then the next day you are saying the same thing. People will begin to wonder, this guy, something is wrong. So yes, you have auditory. We are not hearing anything, but you say you are hearing. The client will be talking, okay, what they are seeing, they are hearing. Yes. The hearing aspect is the most dangerous thing about hallucination because when they hear that go and kill Olubumi and and Olubumi does not know what is going on in the mind of that patient, the patient will come and kill you. So command, we call it command hallucination. Yeah, something is commanding them to do. Yes. So you always have to assess. Can you tell me what okay, let them communicate. Okay, because command hallucination may instruct the client to harm themselves or others. They will use their head and be hitting the wall of that care home. Okay. Yes. So don't validate their feeling. You acknowledge it, but don't validate it. Okay. Either I tell them that I don't hear the voices, but I understand that you are hot hearing. This is an acknowledgement. Okay. You acknowledge. It's a sign of respect. Okay. Delusions is another positive thingy that we're gonna talk about. Okay. Delusion is another positive thing. Good. So delusion is what? A false belief. A false belief. Despite contradictory evidence, we have given you evidence, but still, okay, it's a false belief. For them, it's not like they are not seeing, they are seeing. Okay, it's their see. Like this airport. You ask them, "Ah, what is this? This is an airport. Okay. What is the color? Okay. They will say the color is red. But this is white. This is white. We will go and bring another thing that is white. Okay. We will bring them another thing. Ah, what is this? This is white. Then why is this not white? Okay. He said, no, 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 this is red. Okay, yes. So these are false beliefs. These are all thought processes that is going on. Okay, so somebody will say, the government is trying to kill me. It's persecution. Okay, persecution delusions. Yes. Are you sure the government is trying to kill you? So grandiosity, yes, they think big. Okay, I control the entire world. Are you sure? You are just here. Even your own clothes, you can't buy somebody's clothes you are wearing. You want to buy this one, you are being grandiose. Okay, it's a false belief. Whatever you say you are seeing or whatever, nobody can accept that. Then referential delusions. The news anchor is sending secret messages specifically to me. Yes, sometimes everybody has the same thing. You are friends, you are working together. Okay, two of them will be talking about something. You think they are talking about you. Ah, this one that they are sitting somewhere talking. I'm sure they are talking about me. Referential delusions. They will tell you that, how can we talk about you? Who are you? They say, no, so do not argue with them. It's in psychiatry or in the psychiatric patient, don't argue with them. Don't validate whatever they are saying and don't ridicule them. Instead, you acknowledge their feeling. It's a sign, acknowledgement is a sign of respect. It's respect what they are. The fact that I don't agree with you does not mean I don't respect what you are going through. That is an acknowledgement. Then you present them the reality. Okay. Instead, this is the real. This is white. Okay, this is the color white. Okay, you can go and bring a chart with objects and their colors, maybe they're written in the book with pictures. Then you tell them, oh, this is white. You see, even the book is saying this is white, color white. So this one too is white. Okay, so you have presented them the truth. Then you focus on their safety because you don't know what is influencing their mind to think that way. So that thing that is influencing their mind can also influence them to come and harm you and harm themselves. So you focus on safety, keep eyes on them, monitor them. Okay, perfect. So these are the positive, these are the negatives. Let's do antipsychotic medications. Since we have entered into psychosis, or psychosis, let us do psychotic medications. Okay, so the way I've arranged it, when you get it, learning will be so easy for you. So antipsychotics are divided into two. We have the first generation and the second generation. Okay, anytime you hear first generation antibiotics, this one, it means that they first created this medication. They first created it when we wanted to treat people with psychosis, with positive symptoms. We first created these medications. Along the line, we realized that these medications were doing more harm than good, although we were able to achieve our aim of calming people down, making sure that they don't get relapse. But the side effect of these medications were terrible. Okay, so we now brought another type of medication, another group of medications. We call them the second generation medications. Yes, the second generation medications came to solve the reason why we created the first medications. And also, on top of that, the side effects were less. Just that sometimes some one or two patients, when they take the second generation medications, they will also have the signs and symptoms and the side effect like somebody taking first generation. That is it. Okay. So, example, haloperidol or Haldol. Haldol is what? A first generation medication. If you keep taking Haldol for a long time, whether you are young, whether you are long, whether you are short, whether you are fat, irrespective of how you are as a human being, once you are a human being on earth, irrespective of how you are, you exhibit what? A time is coming, you exhibit what? Extra pyramidal symptoms. Okay, that is the because you have taken a first generation medication. But when you take a medication like risperidone and all this quetiapine and all those ones, okay, second generation medication, quetiapine, we can get 1,000 human beings taking quetiapine, only two or three. Even that once a while, they will get what? EPS. So if you've built a hospital that you want to take care of psychiatric patients and you go to the market to buy medications, what do you do? Which one will you buy? Won't you go to the second generation and buy them? Yes, it's safer to use, not always, okay, but it's safer and is calmer, and I'm also able to achieve my aim. That is it. So we have the Haldor and we have the CPZ for the first generation. Second generation, we have the don guys and the pine guys. Okay. Yes. So quetiapine, lazepine, clozapine, all of them. Go and see Nicholas. He has an acronym for that. Okay. So he he will teach you all the acronyms there. Okay. Right. Oh, important adverse effect category include extrapyramidal symptoms, the tardive dyskinesia, neurotic malignant syndromes, and we are going to go through all those ones. Okay, right. Sometimes too, some patients will be having some metabolic dysregulations, orthostatic hypotensions, sedation, and anticholinergic effects whilst taking these antipsychotics. Okay, so let's take them extra pyramidal. Those people who are taking the first generation antipsychotics, they take it for a long time and they begin to have what? Extra pyramidal symptoms. Okay, so the extra pyramidal symptoms, what does it mean? What is the meaning of this English? I have taken the medication at 0 level. My aim is that this medication should hit 100. level, frequency. Okay. This medication has hit the 100. I am achieving what? A calm patient. My patient is not having psychotic symptoms again. Anything above this 100 is what? Is above the pyramid. So when a patient keeps taking the medication and they hit this zone, they will start exhibiting what? EPS, tardive and all these NMS, neuroleptic malignant syndromes. Okay, and the other ones. Okay, so when you take EPS, we have under it the first signs and symptoms to tell you that no trouble is on the way coming. This medication I'm taking, I have to keep eyes on it. Is what? Acute dystonia. Acute dystonia. It will start having effect on your muscles. Acute dystonia. What is dystonicity? Tonicity, muscle tonicity is the ability of the muscles to what? To respond, to be excitable. Okay, if I touch you, you shake. If I do this, you do this. Okay, but if I touch you, and you're shaking, you are not stopping. What is going on? Your muscles are hot, overly, or they are responding to me aggressively, or sometimes to. It's like they are responding and hypo responding. That is acute dystonia. So you'll be getting all this where the spasms coming from. Some of the jaws. Think about where muscles are. Okay. Yes. So this patient is taking the medication. Sometimes you see them having some spasms, like somebody who is withdrawing from alcohol, tongue protrusion, and oculogyral crisis. Okay, yes. So this can become an emergency if the airway is affected. So that is the first sign. The muscle is what? Having dystonia. Okay. Number two, if you don't do anything about this dystonia, the next thing you are going to have, the next complication you're going to have about extrapyramidal symptoms, EPS, is what? Akathisia. Akathisia in Ghana, akathisia is a young teenager who is very restless and doesn't stay at one place. So when we tell you sit down, you stand. Don't run, you run. He never listens to advice. Yes, it's a term in Ghana, akathisia. Akathisia is a muscle problem. Okay, so there's a constant movement, and the major problem over here is what their vital signs, especially their heart rate and blood pressure, and their respiration rate. Okay, it is always high. So this one we do symptomatic treatment. Symptomatic treatment. Symptomatic treatment. Over here, you give them medications to calm the muscles down, those anxiolytics. You give it to calm the muscles down because of the spasms. Calm it down, calm it down, calm it down. Okay, by here, forget about the muscle. Think about the blood vital signs because the vital signs are getting involved. Okay, blood pressure is shooting, antihypertensive one. Heart rate is going high. What should I give to drop the heart rate down? Okay, so these are the things you do. Keep them on a heart monitor if they are with you. Okay, yes. So they can't sit still. Then the next one, if you don't do anything about the akathisia, you don't do anything about the akathisia, the next one they will do is what? The Parkinsonism. The Parkinsonism. Forget about the drug induced Parkinsonism. Okay. Parkinsonism. In Parkinsonism, this amygdala in the brain, which is responsible for producing what? Dopamine. Dopamine will help the muscles to coordinate and work perfectly. If the muscles don't get dopamine, they will run into what? Rigidity. Okay, they will go into rigidity, so it keeps them calm. So you see those guys who take those doping medications, you give it to them, they will become calm, quiet, tremor. Yes, they can stand at one place for days. Okay, okay. So, Parkinsonism, this amygdala is intact. There is no trouble with it. Just that their nerve that is supposed to carry this dopamine from this area to the muscles for the muscles to work well. There is a trouble on the way. So the dopamine is not reaching the muscles. So the muscle will begin to become rigid. Okay, rigid, fixed. So sometimes when it starts, they will be getting some tremors, then the rigidity will come in, bradykinesia and shuffling gait. Rigidity is their marked signs and symptoms with Parkinsonism. It is different from Parkinson. Parkinson, the nerve that is supposed to transfer the dopamine to the muscles are intact. Just that the amygdala here, the cells are dying and the cells cannot regenerate. So if you have 100 cells here, all of them are dead and it's left with 20. So only few dopamine is able to produce and come here. So you see the Parkinson's guys, it will be like that. Then they die from it. So the DAP, always the DAP of what the APS, extrapyramidal effect, the acute dystonia, the akathisia, and the Parkinson's. We are done with it. Okay. Tardive dyskinesia. If you don't do anything about this one, they will go to another level. We call the TDs, tardive dyskinesia. You see it in NCLEX a lot. Yes, that is where you begin to see the serious facial movement, tongue movement, okay, the coriform movement, and the lip smackings. Okay, these signs and symptoms will become persistent. And remember, once the patient hits tardive dyskinesia, their problem is irreversible. They are going to die with it. Just psychosis, and I started haloperidol on you. See where I've ended. Okay, see where I've ended. So over here, the Parkinsonism, you give them medications that has dopamine in it. So any medication with dopa attached to it. Example is what? Levodopa, dopa, whatever. Any medication with dopa attached to it, you give it to them to help the muscles to work. Okay, so you should know. Tardive dyskinesia, they are irreversible problems. Okay, you treat them symptomatically, you help them with activities of daily living. Okay, you give them medications to calm them sometimes. If they are having tremors and all those stuffs, you give medications to solve that one. Okay, tardive dyskinesia. And so this is one bracket, extrapyramidal symptom, EPS. So in EPS, the first signs and symptom is what? Dystonia. The second is what? Tardive dyskinesia. Akathisia. And the third is what? Tardive, the DAP, is the Parkinson's, the DAP. If you don't do anything about these three guys, they will enter into an irreversible mode. And the mode is called what? Some people make it 4, or some people make it asterisk. We call it the tardive dyskinesia, the TD. Whilst they are battling with tardive dyskinesia, on the other side, they can get another condition too, called what? Neuroleptic malignant syndrome. So your nervous system signs and symptoms you are getting from all this extrapyramidal it will now become like something like cancerous. It has gained energy, strength. They have traveled. They are conquering your body. So your problem becomes what malignant, and it's a syndrome with coming to you with so many signs and symptoms. This one, a lot of patients don't get to this stage. Okay, it's a rare, but when you get here, it is potentially fatal antipsychotic complications. Okay, so they get severe rigidity, autonomic instability, autonomic nervous system, the sympathetic and the parasympathetics. Okay, imagine when it hijacks your parasympathetics, your blood pressure will be dropping, your heart rate will be dropping. When it hijacks your sympathetic, I mean, there is fever and altered mental status. So patient will be having a severe muscle rigidity, tachycardia. It's like a mixture of all those signs and symptoms we saw from above here with severe rigidity. But the other thing is, it's like I've hold your muscle, the way we hold towel and we bend, we squeeze it like this. It's like I'm holding your muscle and I'm squeezing it. Neuroleptic malignant syndrome. That is hard. If I squeeze it and I hold it like this, can you move the muscle? No, the muscle will become rigid. The water, the enzyme in the muscle will squeeze out. That is why we get what? Elevated creatinine kinase. Creatinine kinase, when it increases in the bloodstream, the kidneys struggle to excrete it. So we begin to destroy the kidneys. Okay, so you hold any offending medication and obtain emergency medical evaluation. Simple. Okay, so this is about the the first generation medications. Let's take the second generation medications. Okay, the pine and the dons. Okay, so we look at the first one, the clozapine. Clozapine is effective. A lot of people like using it. Okay, especially when schizo is being or treatment resistant. We have tried other risperidone, all those guys, they are not working. It is trying to be stubborn. You give what clozapine, bam. Okay, and it also sometimes helps them those suicidal thoughts and other stuffs. Some patients will experience suicidal thoughts when they are taking antipsychotics. Clozapine is a gentle guy. You see that gentle guy in the community, everybody admires him. Yes. So, but the problem about clozapine is that it will crash your white blood cell counts. So you have what? Neutropenic issues. Patient will be having malaise, weakness, sore throat, fever, and all those stuffs. Okay, that is it about clozapine. But we use it, then we keep eyes on the white blood cell count. If we see that it is crashing the white blood cell count, then we reduce the dosage a little. So it's like you are using common sense to use this medication. Other serious concerns is what myocarditis, seizures, metabolic, and severe GI hypomobility. Okay. Yes. So let's go to depression medications, antidepressants. We have the SSRIs, SNRIs, and all those guys. Serotonin, everybody likes serotonin. Serotonin should go, the happy hormone, serotonin. Yes, I'm smiling now because serotonin is making me happy. Yes. We have sent serotonin from the brain. Serotonin is coming to you, the cells. Somebody has catch serotonin on the way. Okay. Yes. When it happens like that, the cells here will begin to become what? Moody. Okay. Is that the only way we can send serotonin to the cell? No. Let us give the patient serotonin to swallow. We will use another pathway to send serotonin to this patient so that, yes, okay, brain, take your nerve. We don't want your serotonin again. Let me give you serotonin. Simple. The patient will be taking serotonin, fluoxetine, escitalopram, and all those guys. That is what they do. Okay. Yes. But happiness and over happiness is not good for us. It is time for us to sleep. Melatonin must come and help us to sleep. Patient is taking serotonin. Is the patient going to sleep in the night? No. So sleeplessness. Sexual dysfunction. Okay. Yes. And all those ones. GI hypermotility. Okay. And hyponatremia, bleeding risk, serotonin syndrome. You are taking, especially those who take all this. Is it St. John's wort? There is one leaf that has serotonin in it. Okay. You are taking serotonin tablet. Then you went home and you went for prayer camp. And the pastor said that, oh, I saw one Sobolo drink. Okay. Come and take it and not knowing they have used serotonin leaf inside. You get drink, you get excess toxicity of serotonin, you get all serotonin syndrome. Okay, so this one, when it happens like that, we have to manage you symptomatically. Okay, but I mean, a lot of people recover. So it occurs because of excessive serotogenic activity, often involving medication combination or dose changes. Some patients, they are taking, let's say, 10 milligram of serotonin. Then they change it to maybe 20 milligram. When they start taking the 20 milligram, their serum concentration increases and they get what? Toxicity. Okay. So agitation, happiness, confusion, fever, tachycardia, diaphoresis, hyperreflexia, clonus, shaking, tremors, all these are signs and symptoms. Okay. So serotonin syndrome is what? Hyperreflexia. Okay. Yes. And neuromuscular and neuroleptic malignant syndrome, you think about what? Rigidity. Okay. Yes. So monoamine oxidase inhibitor. Okay. Monoamine oxidase inhibitor. Monoamine oxidase inhibitor. Monoamine oxidase inhibitor. Okay. So I told you this is the brain and this is the nerve. It has sent serotonin to here. Serotonin came to a junction. We call it the neuromuscular junction. Brought the serotonin to a serotonin transporter here. The serotonin transporter sent the serotonin to this area and the journey continued and the cells were happy. They got their serotonin. Okay. But in this gap, there is some Goro boys here. There is some Goro boys here. That what do they want? Their duty is that if you travel on the desert, we have some people on the desert. When you get to the desert, they will hijack you, they will steal you, they will take all your things from you. Okay. Yes, sometimes too, the driver has delivered the serotonin. The driver is going back. These Guru boys, they hijack the driver and kill it. Serotonin will get here. Is there any driver to pick? No driver. Driver has been hijacked, has been kidnapped here. What is the name of these kidnappers? We call them monoamine oxidase. MAO. If I want to destroy these MAOs, I have to bring another medication that will come and inhibit the activities of the MAO so that this driver can go and come and go and come and go and come so that he can transport the serotonin and all these happiness hormones to my cells and everything will be normal. So what is the name of the medication we manufactured? The name of the medication was named after the Goro boys here. So we call them the monoamide oxidase inhibitors. That is it. But the problem about this inhibitor, because this is going to be a serious war. Imagine you are sending soldiers to the desert to go and fight Goro boys on the desert. It's going to be a serious battle before they are able to overcome. So when the patients start taking it, they get what we call hypertensive crisis. Not everyone, but majority of the patients would get what hypertensive crisis. So patient taking MAOs, OIs, and they start complaining severe headache, blood pressure, palpitation, nausea. No, signs and symptoms of blood pressure shooting up. Neurological symptoms. No, you have to keep eyes on and report to the doctor. Okay, good. Now let's go to benzodiazepines. We use benzodiazepines for what? To calm patients down. Anxiolytics, the benzos. Okay, example is the lorazepam, diazepam, diprazolam. Yes, so we use it in a mild form to calm the midazolam to calm them down. Okay, but when your patient is taking this, because it depresses the central nervous system, and even in higher doses, it can sometimes depress the respiration in the cardiovascular system. So, orthostatic hypotension, dizziness, lightheadedness, all those ones. Okay, so we keep eyes on what risk of falls. Okay, psychiatry is the cheapest thing. It's the cheapest topic in English. Okay, yes, sedation. It sometimes sedates them. A lot of people, because of the anxiety they are taking, they are going through, when you give them lorazepam, they will sleep the whole night. Imagine a patient who is not having cannot sleep in the night, and you give lorazepam and he slept. This medication, what is the name? They will depend on it. Overly dependence. If you allow them to be taken, one day you go and meet them in the room dead. They will overdose it. They will abuse. Because the time is coming, the body will not be comfortable with only one tablet. So they have to pack it, pile it. They can take 2 or 3. We can seize their respiratory system. Okay. So respiratory depression, especially central nervous system depression. Okay. Are we able, people who are overly dependent on this medication, we are also going to have another issue with what? Withdrawals, because the day you want to stop them from taking this medication, their body will react. They'll get withdrawal symptoms. Okay, so in the hospital, we always do PRN for these guys. Okay, but some of the patients, 12 midnight, they are asleep. They will wake up 12 midnight, go and use the bathroom, ring the call bell. That please, can you give me this? Can you give me some? Yes. So the antidote, when they start getting all these issues, the antidote to withdraw the benzodiazepam or to reverse it, especially if they get toxicity, is to what? Is to reverse. So flumazenil will do that job for us. Okay. Substance abuse. Substance abuse. So NCLEX may test you on intoxication. It is a major issue in every hospital in US. Substance abuse. So substance, we are looking at the drug side. So substance abuse, we are looking at the drug side. And we are looking at what? Alcohol. Okay. If you take plenty drugs, especially these opioids, if you take it plenty, you'll be intoxicated. The same as what the alcohol intoxication. Yes. If they stop taking it too, some people will go to rehab that they want to stop taking it. They will finish the rehab session, come back home, and their body will start withdrawing. Okay. So either of the angle, they have problems. Intoxication and withdrawal, safety, overdosing, therapeutic communication. A patient has come to the hospital. He is asking you permission that, please, can you allow me to go and smoke? Can you allow me to go and do this? Can you allow me to go and do that? No. So those people who are having smoking issues, when they come to the hospital, how can the nurse help them? The nurse will tell the doctor that, please, can you prescribe some patch, nicotine patch? Okay, nicotine patch. Let us use for this patient. Nicotine patch, so that we apply it. Okay, you do your assessment, you do your intoxication, the sedations, and all those ones. Okay, the withdrawals too, you do your withdrawal scoring, especially with the alcohol withdrawal. Okay, yes, you do your alcohol withdrawal and you do your opioid withdrawal. Okay, so don't judge patients and don't use judgmental words. The care should be person centered and clients with alcohol use disorder. Okay. Yes, rather than stigmatizing the labels and all those ones. So let's talk about alcohol withdrawal. A person taking alcohol withdrawal, having alcohol withdrawal, it means that they have taken alcohol for so many days, months, years. They are not getting alcohol again, and they withdraw. If the simple way to understand withdrawal and their signs and symptoms is that a boy and a girl are dating. They love each other so much that one day trouble came, the relationship is broken. The boy is here and the girl is here. No matter who they are, one of them will miss each other. The other, no matter what. A day is coming, you'll be sitting down and you'll be reflecting. I wish this person was you. I wish this person was you. I wish this. So at that moment, you begin to become anxious. Okay, some people will be restless. Okay, some people will be having all these mood disturbances. So this is what a sign of what you are withdrawing from your ex. You want your ex back. Some of them will come and look for their ex. When they come and their ex has married or their ex has done, they go and fight the new partner. That no, by force, I want my ex. So this is a sign of withdrawal. So if you take alcohol for a long time, you'll be getting what? Tremors. Take it for a long time, all of a sudden you stop. Tremors, anxiety, insomnia, diaphoresis, tachycardia, hypertension, and nausea. Okay, severe forms of withdrawal, they get seizures. That is why no nurse in this world wants to get alcohol seizures. Okay, wants to get alcohol seizures. So the hallucinations, the autonomic instability, and the delirium tremens. Okay, so we have a certain tool we call the CIWA. 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 It is used for you to know that no, this withdrawal, is it serious or it is mild or it is moderate or what? And the score you get, the higher the score, the faster the reassessment and the higher the dosage of those phenobabs. Phenobab. Because this patient who is having all these anxiety signs and symptoms as a result of withdrawal, sometimes even with seizures, you can't give them lorazepam to calm them down. No, we have to give them a higher version of what? Anxiolytics. We call it phenobarbital. But you can't give phenobarbital without knowing your CIWA score. Okay, so if I do a CIWA and the CIWA is, let's say, I got CWA of, let's say, 18. I'll be giving Philobab. Philobab is either oral or IM injection or IV. Okay. Yes. So if I want to do oral, I can be giving like 30 milligrams or no, 60 milligrams. So that is going to be like 2 tablets. But if I get a CWA of, let's say, 10, I'll give a lower dose of Philobab. It means the patient is recovering. Okay, so never rush to give phenobarbital if you don't know your CWA. Okay, yes. Why are we preventing or why are we doing all these clinical stuffs? Because we want to prevent them from getting seizures and also another condition called delirium tremens. Okay, it's a life-threatening condition. It can kill the patient. Okay, your patient can be getting a heart rate of 170, 180 because of alcohol withdrawal. So imagine this is an arrhythmia, sinus tachycardia. It's an arrhythmia. Okay, it can stop their heart. They are hallucinating, they are agitated. So you give the Philobab, it will calm them, they will sleep. There are some patients, you give them nicotine patch. You also give them nicotine gum to be chewing to calm them down. Okay, yes. So that is how it is. Let's go to opioid. The two major, if NCLEX wants to test you on withdrawals, it is going to be alcohol or opioid. Write it everywhere. You come back and say that no, Paul Bright, you said it. Write it anywhere. If alcohol wants, NCLEX wants to test you, they will test you on these two, on withdrawals. Okay, so opioid too. Somebody is intoxicated with opioid. Opioid will depress your central nervous system, depress your cardiovascular and your respiratory system. Okay, so when patient is intoxicated, they are pinpoint. You know the pin that tailors and seamstress they use to sew clothes. Look at the tip of the pin. It's look at the dot I'm creating on the page. This dot. The tip of the pin is like this. Your people, that your black. That when you open your eyes, the black, inside the black, there's another black. That is called the people. It helps you to see. Okay. The people, it is very sensitive. Okay. Whatever is going on in your brain, the size of the people interpret it. Okay. The size of the people interpret it. When your brain cells are dying or when the body is dying, the people become big, dilated, and fixed. Okay, nothing can move it. It becomes totally insensitive. But when you take opioids and the opioids are crushing you, they are causing the intoxication. The pupils will shrink. It will become so small. Okay, yes. I should tell you that no, this person is having opioid intoxication. Okay, so you need to reverse it, and reversing is the naloxone. They give you a naloxone to reverse. Now let's go to withdrawal. If the person is not getting opioid to take, they will withdraw. So, like this guy was going through all these hyper issues, they too will be having the hyper, the diarrhea, the vomiting, the cramps, the piloerections, the lacrimations, the yawning, the rhinorrhea, goosebumps all over, muscle aches. Yes. So they withdraw. Okay. They withdraw from the opioid. So you do your opioid scoring. You call it the opiates or the cows. Look at it. The cows. Okay. So the CWA is for the alcohol and the cows, the opioid withdrawal scoring. Okay. Is for the is for the opioids. So you get your cow, then you give medication. You get your cow, then you give. That's it. If you get a patient who has both alcohol and opioid withdrawals, so the very moment you do your CWA, do your cows so that you know how to give your phenobarbs. Okay, phenobarbitons. That's it. Good. You keep the patient on heart monitor because you need to know what is going on, the respiratory arrhythmias and all those stuffs. Okay, GCS and all those stuffs. Okay, right. Let's look at abuse and neglect. Abuse and neglect. We have 5 minutes, but I think I'll borrow some time. Okay, abuse and neglect. So, uh, abuse and neglect is a major public health concern in NCLEX. So, which people can be abused or neglected? Children, partners, intimate partners, older adults, and vulnerable adults. Okay, how will you know? What are the signs of abuse or neglect? Injuries on the body of the person, inconsistent with history. Example, let me show you one trick. A mother has brought the child who is, let's say, 6 months. Okay, 6 months old to the hospital, and the child is having bruises on the eye and cuts on the face and all those stuffs. Okay, then you ask the mother what happened. The mother will tell you that the child fell from a table. When we were doing growth and development, 6 months old, can they climb table? So you see the reason why we do growth and development. When you go to police school, you do growth and development. When you go to any school, any social service school, you do growth and development. We do these things to know a child who is an infant. They are the things the child can do and they cannot do. A child who is a toddler, there are things they can do. So when you go and tell your story in the hospital that your child injured themselves and they rate that how old is your child, you don't know what is going on. So you mention the age of the child. You now compare that, is it consistent with the history, this injury, and the age of the child? Does it correlate? Your child fell from the table. Okay. You are abusing the child in the house. Okay. You are abusing the child in the, so you should know how to tell. Sometimes you will report yourself, but you don't know. And they will keep quiet and take the data and call police for you. Yes. So injuries and adults, I mean, so many things. Injuries in different stages of healing. Injuries in different stages of healing. Okay. So one human body. Okay. On the head, we have a cut here on stage 2. Stage 2 wound. On the hand, they have a scratch here on stage 3. Oh, no, stage 1. So this one will be like stage 3. On the leg here. No, why is it that cut? No, somebody has abused this person. Okay. So where are the parents? The parents will say, I don't know this. Okay, you two, you have added your problem on top of neglect. They will call police for you. Okay. Delay in seeking care. When did the incidents happen? And when did you take the patient to the hospital? Okay. Sometimes you are not the one who injured the patient too, but you are the one, let's say this is your child. Okay. Somebody has injured your child. The child is your that person is your church member. You say, oh, because we are family, because we are this, because we are, you don't go. Okay, now the complete complication is becoming bigger. The child cannot even walk again. He's complaining, he's crying the whole night. You will be forced to go to hospital because At that moment, your knowledge is limited. So when did it happen? And when did you come to the hospital? They will call police for you. Okay. Fearfulness in the patient when people get closer to them, they don't want to eat, they are malnourished, neglect adults, old people, okay, vulnerable individuals, poor hygiene. They are covered, especially those patients in care home, cover the poop and all these ones. Their diapers is not changed. All these ones we assess when they come to the ER. Diaper, when you see a fresh diaper, you know that this one has been changed. This one has not been changed. Bruises all over. So we have a certain phone. We take pictures of all those ones and we show we show it to the police and report. Okay, frequent unexplained injuries are also there. So interview the client privately when appropriate or if appropriate. Use neutral questions. Don't even ask them so that they would, especially the old people who are vulnerable. Your husband has beaten you. So you the nurse must ask questions that will not even bring the mind that if I say anything, I'll put my husband in trouble. Oh. No, or my wife in trouble. So can you tell me how this injury happened? Some of the questions. You document your objective findings. So instead of writing, patient was brutally abused. Document rather, there is a 3 cm purple ecchymotic area noted on the left arm, and a circle has been made around it. Okay, you are monitoring whether it will grow past it or not. Then follow applicable memory reporting laws and institutional procedures. You call the police for them. Okay. Mandatory reporting is very important. Okay. So we are done with that. 29. Intimate partner violence. Partner, man has beaten the wife has beaten the man. Okay. So priorities, safety is important. Don't allow this patient to go home. Keep them, okay, for their safety. Then you do your assessment, your medical treatment, medical clearance. You do your treatment, take vital signs, take blood sample, do scans, X-rays to know everything is fine. Then you plan their safety for them. Then you make their resources referral. Okay, so we need the social worker around, we need the case manager around, we need the police around, we need security around. So all these people will come, the doctor, the family. Okay, so you need all these referrals. Okay, then you respect the client's autonomy within legal requirements. Do not simply command, you must leave immediately. No. Okay. Yes. They like if somebody runs to you, don't send them away. Sexual assault. When a sexual assault, you get a sexual assault case in NCLEX, safety is a priority. Privacy is a priority. Trauma informed care. So trauma care, your ABCDs. Is there any bleeding? Prioritize bleeding. Ask yourself, bleeding, is it active or inactive? Okay. Yes. Arrest hemorrhages. You look the disability, is it affecting their brains? GCS, AFPU, in-depth neurological assessment. Okay. You check their skin, exposure. Okay. Is there bruises anywhere? Sexual assault, the woman. Yes. So all these ones, you check their sexual areas. By experience person, and you have to also respect their right. Okay, you respect their rights, then you check a female should assess the female part to know is there any sperm left there, is there any cut, is there any, yes. And medical evaluation, forensic services when desired or appropriate in accordance to your hospital policy. Do not blame the survivor. That why did you follow this man to the hotel? It's a blame. Do not pressure the client to repeatedly recount the event unnecessarily. No. You are not supposed to pressure anyone to think about the past. It traumatizes them. Okay. Crisis intervention. When you get crisis intervention, everybody and their crisis, everybody and their trauma. But if your crisis come, the way to solve it is one is procedural. Okay. We are looking at what situational crisis or maturational crisis or traumatic or adventitious crisis. Okay. So a situation has occurred. A situation has occurred. It has brought crisis to you. Something has happened. Okay. Your boyfriend has left you. It's a situation. Yes. So you go through some depression, you go through some anxiety, neglect, withdrawals, all these crises. In that phase, we have to manage you. Developmental or maturational crisis. A child is at this stage, okay, when the child was growing, somebody abused him or her. It has left some trauma in their mind. Okay. They are at this age, we are expecting them to write. They are not writing, they are not talking, they are not doing this, they are all developmental. Okay, then the trauma aspect also comes in. Okay. So in caring for a crisis situation, safety, then problem assessment, you identify the support systems, develop immediate plan, and restore functioning of the patient. So crisis intervention focuses on what? The current problem. Okay, the current problem. Good. Now let's look at grieving and what? Grieving process. So grieving is highly individualized. My sadness cannot be your sadness, and my grief cannot be your grief. Okay. So what are some of the responses we can give? So patient can be sad, anger, guilt, numb, sleep disturbances, appetite changes, and difficulty concentrating. Okay. So never assume everybody follows a rigid sequence of grief stages. No, it will never occur like that. Yes. So you can tell the patient, tell me what this loss has been like for you. Okay. Never tell the patient you need to move on. Okay. See, all of us are surviving. No, no, no. It's a bad statement. Everything happens for a reason. Yes, the church people will come. Ah, Pastor, praise the Lord. Everything happens for a reason. It is God who gives, God who receives. Somebody is having psychosocial trauma crisis. Okay, so what are some of the coping mechanisms we can look at here? Okay, so on that note, we are entering into coping strategies. So adaptive coping, to adapt to the situation. So we can look at what? Exercising. Can we go to exercise together? Can we draw a plan for you? Can you come here every morning? You do some yogas. Okay, we look at problem solving situations. If we have the strength and the resources to help the patient solve the problem. Somebody does not have money to eat the whole day, he has not eaten. You tell the person to go and exercise. I mean, how? You give the person money, problem is solved. Seeking social support. Yes. So social welfare are there, social care, relaxation techniques. Relaxation. The pastors, we teach them, please, you need to sleep. You know that it's too much. Every church member is bringing their problem to you. Okay, you are going through stress, sleep, counseling. People going through so many, the students who are learning and all those stuffs. Appropriate spiritual practices are very also important. Then journaling. Okay, yes. So never use any situation, okay, that will harm the patient or that will traumatize them the more. Okay, yes. Let's look at more adaptive coping. Examples is what? Substance misuse, self-harm, violence, and persistent avoidance that impairs functioning. Okay. Now we've got some few areas to go, then we are done. Defense mechanism. Everybody will defend themselves. Nobody wants to be blamed. Okay. Yes. So everything that happens to you, you find a way to defend yourself. If it's a human being that has hurt you, you defend yourself. Some people will not talk to you again. Some people will block you. Some people will not report you. Some people will do, they are all defense mechanisms. Okay. There are some people too, it's not human being that has harmed them. It is maybe the environment. It rained a lot and their building is broken. They are depressed. They will use defense mechanism. They will avoid, there will be depression, showing all this. They are what? Okay, defense mechanism. So everybody and their defense mechanism. What situation? So some say, some use the mechanism of denial. Yes, the doctor says I have cancer, but there is nothing wrong with me. The very first day you are told that you have this disease, you deny it. Your body will tell you, no, 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 no. As a child of God, as a child of this, why should I have this? This it's a denial statement. Okay. Projection, you are projecting, you are attributing your feelings to another person. Okay. Yes, you are projecting. Everybody sees that you are angry, but you are saying that what? It is rather we who are angry. Eh? You are projecting the feeling you are going through. I mean, everything is written all over you. Okay, but you're rather projecting it to us like the projector. The problem is here. The way the projector works. Okay, we connect the computer to the projector machine, and the projector will project the image to a wall. Projector, why don't you show us the image? No, somebody must show it. So that is it. Displacement, the difference, if you are not careful, you think they are the same. Okay. Displacement is what? Redirecting emotions toward a safe target. Okay, toward a safe target. So in projection, we project or we send our feelings to anybody. Okay, whether a young person, whether our pastor, whatever, whoever we see, we project it to. That no, you are going through this, but not me. No. Okay, that is projection. Displacement. In displacement, we look at somebody we can bully, somebody we think that will be weak, somebody you think that we can blame, then we put the blame on them. Okay, you redirect your problems to a safer target. So the supervisor who is angry, something is going on at work. The supervisor thinks, I want to use these people as scapegoats. Okay, yes, so they will target you. So it's not everybody who comes to you and rebuke you that you should humble yourself for. Sometimes you need to fight for your freedom because according to the person, you are the weakest person he or she can attack. Okay, yes. Then rationalizing, creating an acceptable explanation for behavior. Example, I failed because the test was unfair. You are rationalizing you. Everything you rationalize. Okay. You never accept your behavior. You've done this. We are complaining. You are rationalizing. Yes, I did it because you too, you did this. And sometimes people will use this behavior in relationships and marriages, and you are not able to even advise them. It is well. Regression, returning to earlier developmental behavior during stress. So there are some people, when they are going through stress or when they are going through some emotional disturbance, you see them bedwetting, you see them having all this chewing their tongue, their fingernails, behaviors that when we were a child, when we were children, we were doing it. Now you are old. Because of stress, you are doing this. Okay, that is regression. Then sublimation, like what the camphor, redirecting unacceptable impulses into socially acceptable activity. Okay, that is the camphor. When you leave the camphor, the naphthalene, when you leave it there, when air blows over it, it will vanish. Okay, yes. So somebody is an armed robber. He robs very much, very well. Okay. Now he will use his robbery skills to help the police to develop a device that will help people, or that will, yes. So your problem you are having, that knowledge you are having, then you have not told yourself that you want to stop the robbery. Okay, but you want to use that knowledge that you use to rob people to help the police to devise a device so that they will be catching other thieves. But you are not stopping what you are doing. Okay, yes, that is sublimation. So they sublime to, so anger, you are a very angry person, but you say, okay, let me go and do exercise. Is the anger gone? No, the anger is still there. The exercise you are doing, nobody will blame you. If somebody sees you at the gym, will they complain? No, they will not complain. Okay, that's it. Then reaction formation, behaving opposite to one's unacceptable feelings. Yes, so we always react to when people mess up to us. So you are doing reaction. This one, everybody does it on the page. Good. Personality disorders. So we have the borderline personality, so many personality, antisocial. We have, then we will do the eating disorders. Okay. So the borderline personality disorders, they are unstable. It may involve unstable relationship, fear of abandonment, impulsivity, emotional instability. For this topic, I'll ask you to go to the slide and get the details of it, because we have so many types of personality disorders that you need to go through. Okay, yes. Cluster A, cluster B, and cluster C people. Okay, yeah. So emotional instability can let people assume certain personalities that no. In Ghana, we say that it is because of a human being. That is why we have 2 6 o'clock, 2 6 o'clocks in a day, because of a human being. So it's a nipa nema no nsia ebo. Okay, yes. So because of human beings, because of somebody who make you change your lifestyle. Yeah. So it's not like nobody was born like that, but people will make you change. So consistency with these people with personalities, especially borderline, consistency is very. If you are dealing with them, you have to be consistent. You set your clear boundaries. If you set the boundaries, don't break it. If you break it, gaining their trust is very important. It's very difficult to get it. Okay, consistent expectations and unified treatment plan, especially with them. Okay, good. Antisocial. So, antisocial people, They have disregard for others, deception, manipulation, impulsivity, and lack of remorse. These are some of their behaviors. So when you are dealing with them, you set clear rules, consistent consequences. Yes, if they mess up, punish them. Okay, yes, and firm boundaries. Personality disorders, boundaries is very important. Yeah, you can live with them. If I live in with you, and you don't regard me, I'll also set my boundaries, and I'll be firm with it. That okay, we are living in the same house. Fine, life goes on. Okay. Ah, and if you mess up with me, I'll give it to you so that you know that you messed up with me. Okay. Eating disorders. So we have the anorexia nervosa. Yeah. So anorexia nervosa, they eat, they eat. No, they don't eat. Okay. They don't eat because they think if they eat, they are going to gain weight. Okay, they are very particular about their skin, their appearance, and their body. So they want to look good, nice, always hitting the gym, looking nice. Okay, yes, electrolyte imbalance, protein. They are not eating a lot. You are lacking protein, muscles issue. Okay, they don't want to gain weight. They are always weighing themselves and all those stuffs. Okay, so they will have lower heart rate, hypotension, electrolyte imbalance, arrhythmias. Mm. You focus on their medical stability, it's very important, and electrolyte balancing. Okay, bulimia nervosa, they will eat but induce vomiting. If you induce vomiting, you are bringing out electrolyte from your stomach, and the key is what? Sodium, potassium, chlorine, hypokalemia, as a result of what? Inadequate intake and inadequate digestion of the potassium in the food you eat. Okay, yes. And if you're having issues with potassium, you are going to definitely get arrhythmias. Okay, yes. So we have parotic enlargement, esophageal injury, calluses of the knuckles, and dental enamel erosion. Okay, weak bones. Yes, the calcium, everything is low. So these are the things you should know. Then somatiform disorder, somatic symptom disorder. The client experiences genuine distress related to physical symptoms and excessive thought of feelings or behaviors around them. Okay. The symptoms should not be dismissed as it is all in your head. No. The nurse should rather acknowledge. There is somebody who has come to the hospital that I'm having headache. We have done CT scan. We have done MRI. We have done everything. We can't see any tumor, any whatever. The CSF is intact, volume is perfect, brain cells are intact, blood vessels are intact. Okay, the muscles, the meninges, whatever, the bones are intact. Where is the headache coming from? We have checked your electrolyte, all the signs and symptoms, all the investigations we have to do to catch up to confirm headache. We have done. Still, nigga will go home, come back again with the same problem. Okay, so you are thinking you have a particular physical disorder that nobody can confirm it. Even when we tell you there is no problem, you don't believe us. These are the people with a mental problem. Okay. Yes. And they will do doctor shopping. They will go from this hospital, this. They when they get their salary, they will go straight to hospital to go and do laboratory investigations. The good thing about these people is that they live long because their eyes are on their physical health. Okay. They live long. Unlike people who are sedentary, they don't care, they are collecting money. Okay. 2, 3 years, they've never been to the hospital before and they are happy. Me, the whole year I was never in the hospital, not even to do laboratory investigations, blood works. You did not do. You are happy. One day you'll be there and they will tell you that cancer has developed in this area of your body. Then you'll be surprised. Okay. You are always eating, but you don't keep eyes on your cells in your blood works. Okay. Right. Getting to the close, dementia and delirium. Okay. I did dementia for you. So, dementia is a progressive neurological damage. Okay. Yes. So the nerves in the brain, they are dying. Some of them are wasting. They are not repairing. Okay. Yes. So you begin to get what? Memory issues. Memory issues. Okay. Yeah. So that is dementia. It can happen to anyone, but there are some people too. It is genetics. So if you come from a family with dementia, there's a higher probability that you'll be getting dementia. Okay. Infection and all these ones can cause it. Dementia, early dementia. The higher forms of dementia is Alzheimer's. Yes, Alzheimer. Okay. So most patients, they take memantine, memory, to boost their memory, When you are young, they say take honey. They have so many medical products, herbal products that you can take to boost your memory. Okay. You eat good, you exercise good, keep yourselves nice, well, and that's it. You look fit. Okay. So dementia is what? Progressive, and often preserved early. But usually you start seeing the signs and symptoms too late. Imagine your brain cells that are responsible for memory is dying. It will take like 20, 30 years for you to see it. So the fact that today you don't remember anything again, okay, you see us, you talk to us like I'm talking to you nicely. I'm talking well, you understand perfectly. But tomorrow, come and ask me, what did we learn today? I don't know. I will behave as if we never even had any class today. No, you have a problem with your memory box. Okay. Yes. It is irreversible. And progression depends on the cause of it. Okay. Yes. Is it aging or what? Then delirium. With delirium, we don't have any issue with what? The nerves destroying or dying. Okay. Yes. And with delirium, I would see delirium as confusion. You're confused. Okay. The adults who are having urinary tract infection, delirious, balancing. Once you become delirious, you're balancing your false risk, injury risk, all these ones will come in. And it is reversible. So with delirium, look for the causes like infection, whatever, dehydration, blood issues, okay, electrolyte imbalancing. So once you treat the cause, the delirium will what? Vanish away. That is it. So that is where. So sudden confusion, investigate an underlying cause. So with delirium, you can think about infection, hypoxia, medications. Some people will be taking medications like lorazepam. They get serious delirium. Okay, when it happens like that, don't give them again. Then you wait for the this thing to to wear off from the body. Hypoglycemia, withdrawal, and organ dysfunction. Dementia care. Somebody who does not remember yesterday, even when you ask them, they can't remember. But they are remembering and they can talk to you and they can do everything with you. Okay, that is dementia. They talk well, Yes, as they are aging, communication and other neurological deficits will set in, especially when they hit the Alzheimer's stage. And you are going to be with this till you die. Okay. Talking to them, you have to use simple instructions, familiar environment, safety measures. Okay. Clocks and calendar when helpful. So in the care home, even when they want to go for hospital appointment, it is the nurse that will write that, oh, this person has hospital appointment today. Oh. This person has this today. Oh. This man will go and see GP today. Oh. Okay. Because if you don't do, they don't remember anything. It won't work. You do everything for them. Some of them will even poo poo and do everything. You have to even change their diaper in the morning before they even bath. Somebody must even bath them because they've forgotten they have to even bath. Okay. Yeah. So you draw the care plan according to what their dependency ratio. Okay. Aggression and violence. Yes. So escalation and de-escalation. So before somebody will become aggressive, definitely they need something that they are not getting. They are not getting. They will start talking, rushing voice and words. They will be pacing, clenching their feet, loud voice, shouting, threatening behavior. Then aggression will be increasing. At that stage, you need to de-escalate. Go to them. What is your problem? What can we do for you? Okay. Talk to them. Try and calm them down. Okay. Yes. Don't rush to give them what medications to or to restrain them. Okay. Yes. You de-escalate first. Okay. Yes. So safety is very important to protect themselves, you the nurse and others. Because some of them will be using items to hit people, slap people, and all this. Use calm voice and non-threatening posture. In when a patient hits you, eh, go and report the patient because in Africa, one thing I've realized is that we Africans we like to forgive a lot. So if a patient hit us, you say, "Oh, let me just forget." No, go and report so that they will write it down as this is the behavior of the patient, so that they will protect others too. Okay, and they do assessment for you and the patient. Reduce stimulation, exit accesses, and all this assistance from staff. And yeah. So when you do all the de-escalation methods and it doesn't work, okay, you can put on restraint or sometimes you seclude. Okay. Yes. So use least restrictive interventions first. So verbal de-escalation, reduce stimulation, what is making them aggressive, offer choices, address unmet needs, medications when appropriate, or accept what is causing them to be aggressive. Sometimes they need food, but you're going to restrain them. Sometimes they need their medication. Somebody is having Parkinsonism. Okay, they need what? This thing, their dopa, all this levodopa and all this. They are aggressive. Those people have majority of those patients. They will fight you. They will be angry with you. Okay, yes. So solve their problems. If you clear all these things and still is there, then you go to what? Restraining. We restrain, we never use restraint for convenience. Aha. So one nurse was giving patients lorazepam every night as a night nurse because he said the patient is having dementia, he will not sleep. Okay. And in the night, you'll be going to people's room to wake them up. So in the night, you will give zero 0.5 and the woman will sleep all night. Okay. We went to do medication count. Your signature is there. You have given the medication. Okay. What reason did you give the medication? You have no reason. Okay. So you are doing what? Medical restraint. So they later they seized her pin. Okay. Yes. Don't use restraint as punishment. Especially the children. We want to punish them, we restrain them. Then staff retaliation. Okay, don't do that. You should follow the laws and the order and the hospital policy. Okay, and when you do restrain, you should check it regularly and reassess regularly. Okay, reassess regularly. If you think the patient is now calm, the patient does not need restraint, you take off the restraint, you close the care plan, then you also inform the doctor, okay, about it. Restraint. Never put in restraint without doctor's orders. Without doctor's orders. Okay. Then cultural and spiritual care. Okay. Do not assume that all clients from a particular culture share identical beliefs. Yes. You have come to the hospital. You travel as an immigrant. You go to hospital, you see blacks patient. Never think that you have seen Africans, so they should vibe with you. They should do no. Your belief is not their belief. So you are at work, treat them as your patient. That's it. Okay. Yes. So cultural beliefs, some of them they need a pastor to come and pray for, they need this, they need this, their dietary preferences, their family structures, their communication preferences, all these ones you should respect it. Yes. Okay. Then family dynamics. Psychiatric illness affect families as well, not only the patient. So the nurse, if you are educating, educate the families too. Okay, with communications, support communications. Tell them to voice out if they have any concern. Talk to them, encourage them, motivate them. Okay, care identifying caregiver burdens, assessing families' coping mechanisms, then connecting family with resources. I know this behavioral unit here. Can I refer you to this place? Can I refer you to this psych doctor? Can I refer you to this care home? Okay, for rehab services. Yes. So connect them. Then you maintain the family's confidentiality. Okay. So family involvement does not automatically override clients' confidentiality. Involve the family. Let them know that, yeah, we are doing this together. Okay, right. Then the therapeutic milieu. Therapeutic milieu will always provide safety, structure, predictability, and appropriate social interactions. Okay, yes. So clear expectations and opportunities to develop coping skills. Okay, yes. So therapeutically, all these interventions should help the patient and the family and whoever is involved. Okay, I mean, no harm, no, none more efficiency. Do no harm. Okay, yes. So the environment itself becomes part of the treatment, the therapeutic environment. Nicely, no triggers, good lightning, low sound, no interruptions. Okay, good. Electroconvulsive therapy. It is one area that you can also meet in NCLEX. So, ECT, how the nurse should cater for the patient before and after. We do ECT for patients, it's like it's used for some conditions that are severe depression, especially when a rapid response is needed or other treatments have failed. Okay, electroconvulsive therapy. So before ECT, what should the nurse do within the scope of the nurse? You should verify consent according to the policy of the hospital. Nil per auth is very important. Your baseline vital signs and assessment. Remove removable dental applications, appliances when applicable. Then you prepare for anesthesia. When the patient comes back to the unit, your airway, breathing, circulation, vital signs, orientation, and safety. Okay, good. Psychiatric emergencies. In psychiatric emergencies, irrespective of the condition that has come to you, prioritize, okay, any suicidal intention, homicidal. Is there command hallucination? Is there aggression? Is there alcohol? Okay, or benzodiazepine withdrawal? Is it serotonin, neuroleptic, malignant syndrome, severe medication toxicity, eating disorders, delirium from medical emergencies? You prioritize these ones if you see them in your answers. Okay. If you get a lot of psychiatric patients, patients with these issues, prioritize them. Okay. So this is the differential tables. I did this one because if you are to help those who do chill and poor, that's why it's called crash course. This one, the eba. Okay. So somebody has a suicide plan, means, and intent. What are you thinking? A teaser. Oh, this is a high suicide risk. I prioritize. Somebody is having command hallucinations. What comes to the mind of the nurse? I need to immediately assess safety because they can kill and can harm others. Somebody is having fever with what? Severe rigidity. Okay. This is neuroleptic malignant syndrome. These are the tricks that if you learn this and if you are able to capture the psychiatric questions, you catch it because there is no way they will hide it. They will never hide it. If they don't want to write fever, they will write temperature of 40 or 38 or whatever as a sign or it's a fever. Okay, they will change the English. If you see fever with clonus or hyperreflexia, fever with clonus or hyperreflexia, serotonin syndrome. Okay. Confusion, ataxia, and cause tremor. You start thinking about lithium toxicity. Sore throat and on sore throat on clozapine plus fever, possible neutropenic or neutropenia. Okay. So all these ones are there when you get a slide. Someone has come with pinpoint people with respiratory rate very low. Okay. You go opioid toxicity. Cool. Right. And getting to the close end in therapeutic communications, when NCLES asks you which response by the nurse is best, when you see this phrase in your question, always look for answer that will acknowledge and respect their feelings. That explore answers that explores for more informations, answers that doesn't judge, answers that doesn't give advice, answers that doesn't argue. Please go and die on this slide. I beg you. If you want to master psychiatry, okay. Example, a client says, since my husband died, there is no point on in living. Never choose answers that says, don't say that. Your children need you, or everything will get better. Okay, you are giving advice. Okay. If you say this is judgmental, they will take it it's wrong. Okay. Yes. So the next you say that, are you thinking about killing yourself? You should be clear. Okay. Explorative. So in the hierarchy of safety, you ask yourself like the way I started, is there any homicidal or suicidal risk here? Okay. You've gotten so many patients. Which one should I choose from? Psychiatric prioritization. Okay. Which of them is having homicidal, suicide? Okay. So this one is prioritizing hypothesis. So airway, breathing, circulation, severe medication reaction or toxicity, severe withdrawal, acute delirium. Okay. Severe agitation or violence, psychosis. So you get all the rhythm. Okay, right. So in clinical judgment, when they give you questions with clinical judgment and that psychosocial integrity, eh, now they've changed the name. It is no more psychiatry and mental health. It is psychosocial integrity. So when you see this topic on, if you feel your ankles and you give you a test report and you see psychosocial integrity, it means psychiatry and mental health. Okay. In NCLES, when you are dealing with clinical judgment questions, like the way we did it for all the other areas, tomorrow we are continuing with our basic care and comfort. Okay. So you recognize the cues, like yesterday we were doing it. Okay. Then you analyze the cue. So you recognize the cue among all these signs and symptoms, among all these questions. Which questions, ask yourself, recognize cues. Which of these are abnormal among the signs and among the complaints of the patient? Which one is normal, abnormal? Okay. Among the vital signs, which one is abnormal? Among the labs, which one is abnormal? So you have recognized all the abnormals down. Bam, is there. Then you analyze the abnormal. Why is that the patient is having headache in signs and symptoms? Why is it that the blood pressure is so high? Can I link the two physiologically? Okay, yes. Then you look at the labs. Okay, why is it that so and so is so high or so low? Okay, so you analyze the abnormal facts. That is, we call that one analyzing cues. Okay, so you ask yourself, does this suggest immediate suicide risk in psychiatry? Then you prioritize the hypothesis. Those problems that you listed here, abnormal stuff you listed here, you prioritize them. Which one should I go first? In normal medicine, analyzing the cues, you diagnose. But then here you come and analyze, okay, I saw headache, I saw this, I saw this, I saw this. Which one is A, B, C, D? Okay. Which one is airway? Let me solve the airway. Which one is breathing? Let me solve the breathing. Which one is this? So you prioritize. Okay. But in psychiatry, it says that how prioritize what? The violence, the suicide ones, the self-directed violence to kill themselves. Okay. When you do all these things, then you concentrate on the general solutions. What can protect the client now? Eh, now I have suicide case. So you do your suicide workout. Thank you so much. Then you evaluate your care, your outcomes. Okay, good. So this is a master cheat sheet, a cheat sheet that I've added to it. So when you get any condition, any psychiatric conditions and what you are to prioritize, depression, prioritize suicide, mania, safety, and food. Schizo, be real to them. Command hallucination is a priority. People with panic disorders, you prioritize staying with them and using simple. People with OCD, anxiety, and you work on their rituals. PTSD, trauma. Okay, so all these when you get the slide, and this is the master formula that if you want to. So, guys, thank you. Psychiatry is done within, yeah, in some few minutes. Okay, right. Oh, Siwa. Yeah, so Genevieve, if you are still online, let me see the possible side effect of lithium. So lithium possible side effect. It will give you the uppers. Okay. When you say the uppers, like the tachycardias, the running stomach, the diarrheas, and all those ones. Okay. Yeah. So these are the uppers. Then Bright, somebody said bright doper. Oh, more. Okay, so with the Siwa, so come again about the Siwa. Yes, Siwa is what alcohol withdrawal skill. Okay, any patient who is having alcohol withdrawal, you need to score the CWA before you give medications. Without the CWA score, you can't give phenobarbital. Phenobarbital is medication. Phenobarbital, the barbiturates, you can't give because the barbiturates will calm them because they are having agitations, seizures, and all those ones. Don't wait for them to get seizure. If you get seizure, their next thing is the DT, delirium tremens. Okay. So if you are a nurse and your alcohol withdrawal patient gets seizures, you are not a good nurse. It's a bad thing. They will escalate it and they will question you. So your CWA, is it every 30 minutes? Is it every 15 minutes? Is it every 1 hour? Is it every 2 hours or 4 hours? Or so you do your CWA. Okay. Yes. When you do your CWA, the doctor prescribing the barbiturates, they will add. If the CWA score is so and so, give this amount of phenobarbital. If this is within this score, so the scoring and the amount of phenobarbital to give, and that's it. Then you connect the patient to what? The cardiac monitor, the blood pressure curve, the heart rate. Then you check the EKGs and everything. Okay, you get your IV lines. Yes, to check the alcohol levels and all those ones. Okay, right. So I've got some few questions here. Are we tired? If you are not tired, what's the time? Oh my God, it's 5 o'clock. Right. I've got some questions here. I think we have spent more time here, so you are owing me 2 questions to answer. I don't want to waste your time. Okay, I don't want to waste your time. So let's come back. Maybe so tomorrow, the morning session. The morning session, we can be the morning session for tomorrow. Let's use it for our questions, our question bank. So everything we have learned today, this question, please learn everything. This question is 100. It covers all the topics in psychosocial integrity. Okay. Oh yeah, I can do crash course for you within 1 week, and you are done with all the English. Me, I use 1 month for English. Yeah, so yes. So tomorrow morning, let's do the this thing because tomorrow we will we have a class with the main page. So tomorrow morning, let's do our question bank. Okay. Yes. So that we can give ourselves that break, come back in the afternoon and do the main class on basic care and comfort. Okay. Yes. Is it 10 a.m. Ghana time and 11 a.m. UK time? Okay. What's the time in Ghana now? Yes, so I think it's 5 a.m. Or is it 5 or 6 a.m.? Can we do it 5 a.m. so that we can do 2 hours? I beg you. For tomorrow, 7 a.m. I must be at some place. So can we make it 5 a.m. 5 a.m. at my time? 5 a.m. Exactly 5 a.m. Let me know your responses. Or we should 6 a.m. 6 a.m. Then I have to no 6 a.m. won't favor me. I can do 5 to 6:30. Then I leave 1.5 hours. Then I can leave. Yeah. So even between 4:30 to, if you want 2 hours, then it's going to be like 4:30 a.m. Currently my time is 4:55 p.m. 4:55. I don't know for Ghana, the Ghana time now. 4:55 p.m. So, and I know myself and those in Canada will have the same time. Yes. Yeah. So 9 a.m. Yeah. So, and I mean, by that time, you people will be awake. So, even when it's 8 a.m. at your time and you want us to start quickly, we come online, do the questions, then we go. Okay. Oh, depending on, yeah, I know myself and Ontario people are having the same time. Okay. So, guys, see you when I see you. Okay. Stop the share. I see you when I stream you. Yeah. So, thank you so much. Thank you for your time and thank you for everything. Yes, we are having the same time. Those in Ontario. Yes. Yes. Thank you so much. Thank you so much. Okay. Bye bye, everyone. Everybody should say bye bye to me before they go. Bye bye. Let me say bye bye. So tomorrow's time is going to be 5 a.m. Let's say between 4:30 and 5 a.m. we should be online. Okay, 4:30 my time. Oh, I beg. 30 a.m. to 5 a.m. Okay. Yes. Bye bye. So come and let's solve the questions. Tomorrow is purely questions, no physiology, nothing, nothing. Okay. I want to see your bye bye. So Nigeria time, I don't know, Miss Olubumi addressed that one for her. Nigeria time. So 5 a.m. will be what time? It's 8:50. Is it 8:57 now in? Okay. Yes, yes. Post the time there. Yes. Bye bye for everyone. Bye bye. Bye bye, guys. Bye bye. Bye bye, everyone. Bye bye, everyone. Bye bye. Forrester, are you getting the concept now? Are you liking it now? You're liking Enclaves now. Bye bye, everyone. Bye bye. God bless you. God bless you. God bless you. God bless you. Bye bye. Let me know. I want to see your bye bye before you leave. Okay. Bye bye. It was nice time having you. Okay. Bye bye. Goodbye. So tomorrow, the first person to wake up, waking up at dawn is difficult. But the first person to wake up, maybe Tommy. Tommy, you set the alarm for us so that you wake up, wake us up. I beg you, my life is in your hands. Oh my God. Bye bye for now. Okay. Bye bye. Okay. Bye bye. Thank you so much, Aaron Olubumi, for giving us the platform. This is your platform. So whatever you say is where we go with. So draft your time for us. Bye bye for helping us. This is your platform. Okay. All right. 5 p.m. See you. See you guys.